let's jump right into this clinical ward round explainer to lock down the exact next best steps you're going to need for the boards. We're moving fast through high-yield diagnostics and management, distilling the core algorithms you absolutely have to master. No fluff today, just the pure clinical decision logic that separates the novices from the top scorers. 60 seconds on the clock. Imagine you're in the high-stakes environment of the wards, starting right in the pulmonary ICU. The clock is literally ticking. Over the next few minutes, we're going to look at visual cues and hard data to help you differentiate between conditions that might look identical on the surface, like, say, a brain abscess versus TB meningitis, but require completely different management. Picture your first patient. They've got a gradually worsening cough, increased work of breathing, bilateral crackles, and wheezing, but they're still going about their normal day-to-day activities. This is a classic community-acquired pneumonia, or CAP presentation. You need to know the empiric, outpatient treatment for this right away. You literally cannot wait for cultures to come back before you act. So the absolutely crucial point here is choosing the right antibiotic path based on the patient's underlying health. If you've got a healthy outpatient, you're reaching for a macrolide, like azithromycin, or you're going with doxycycline. But if they've got comorbidities, you got to step it up to a respiratory fluoroquinolone or a beta-lactam paired with a macrolide. And here's a highly tested nuance for you. While rusty sputum is classic for pneumococcal pneumonia, these patients can actually present with totally clear sputum. If there's no viral option in your answer choices, do not let clear sputum rule out CAP. Now let's contrast CAP with a COPD exacerbation. A huge differentiator here is that in a COPD flare, systemic symptoms like fever and chills, they're usually completely absent. Instead, the cardinal signs are a sudden spike in dyspnea, increased sputum volume, and increased sputum purulence. And that typical yellow or purulent sputum is actually just from epithelial sloughing. It's not necessarily a sign of a bacterial infection. You only pull the trigger on antibiotics here if they have increased sputum purulence plus at least one other cardinal symptom, or, of course, if they require hospitalization. Fluid analysis is going to dictate your exact next move for pleural effusions. If you tap the fluid and the pH is 7.20 or higher with a lower normal glucose and a negative gram stain, you're looking at an uncomplicated parapneumonic effusion. You just treat the underlying pneumonia with antibiotics. But if that fluid is complicated, meaning the pH drops below 7.20 because of intense bacterial metabolism and inflammation, antibiotics alone just aren't going to cut it. You absolutely must insert a chest tube or surgically drain it. All right, let's move on to a classic board-style vignette. A patient with a history of IV drug use presents with a murmur and multiple bilateral nodular lung opacities on their imaging. What's the immediate diagnosis you should be suspecting here? Burn this image into your brain. These classic peripheral cavitating opacities are septic pulmonary emboli. The pathogenesis is actually pretty fascinating. Injected particles cause microdamage to the right-sided heart valves, specifically the tricuspid valve, before they get filtered out by the lungs. This microdamage makes it super easy for bacteria to attach, most commonly Staph aureus. From that infected valve, pieces break off, launch right into the pulmonary circulation, and cause these cavitating nodular opacities. Now, here's the catch. An audible murmur might actually be completely absent in up to 50% of these cases. And heart failure? Pretty uncommon. So do not rely on hearing a murmur to suspect right-sided infective endocarditis in an IV drug user. The absolute ironclad rule here for management is that your evaluation must begin with getting blood cultures from 3 different venipuncture sites before you give a single drop of antibiotics. Always culture first, then antibiotics. Next up, a highly tested physical exam finding you absolutely cannot afford to miss. A patient presents with a soft scrotal mess. It feels like a bag of worms on the left side, and it actually gets smaller when they lie down. Let's look at the anatomy real quick. A hydrocele is simply fluid accumulation within the tunica vaginalis. It can be communicating, where the patent processus vaginalis lets fluid from the abdominal cavity flow down, or it can be non-communicating. We really need to clearly contrast this fluid-filled presentation against our varicocele vignette. You've got to cement this difference. A varicocele is caused by incompetent venous valves. It's often primary on the left side because the left renal vein literally gets compressed between the superior mesenteric artery and the aorta. That is exactly why it decompresses when the patient is supine. But, and listen up because this is a massive red flag, a right-sided varicocele that has a prepubertal onset and persists when they lie down should raise immediate suspicion for a secondary cause. We're talking about a retroperitoneal mass or a malignancy compressing the inferior vena cava. You must get an abdominal ultrasound. Okay, Shifting gears, the boards love to test your ability to navigate the strict management algorithm for C. diff based on severity markers. Non-severe CDI is your standard profuse watery diarrhea, but it flips to severe the second the leukocyte count jumps above 15,000, or the serum creatinine rises above 1.5. If they're severe or even non-severe, oral fidaxomicin or oral vancomycin are your go-tos. Now, if they become fulminant, meaning hypotension, shock, or megacolon, you've got to hit them hard with high-dose oral vancomycin plus IV metronidazole. Knowing your high-risk culprits for causing C. diff versus your low-risk options is an incredibly easy way to grab points on test day. The high-risk drugs, those include fluoroquinolones, clindamycin, third and fourth generation cephalosporins, and carbapenems. On the flip side, macrolides, TMPSMX, and tetracyclines are low risk. So to minimize the risk of C. diff, lean toward those lower risk options whenever you can. Let's jump into the musculoskeletal ward for our next case. We're looking at the absolute hallmark presentation of ankylosing spondylitis. This inflammatory back pain is insidious. It starts before age 40, lasts longer than 3 months, and here's the kicker. It's relieved with exercise, but absolutely not relieved by rest. These patients also struggle a lot with nocturnal pain. The visual evidence you're looking for is right here in the sacroiliac joint. Notice the subchondral sclerosis and that classic widening of the joint space. You'll pair this imaging with the highly tested HLA-B27 laboratory association, along with elevated inflammatory markers like ESR and CRP, to totally secure your diagnosis. You also need to be ready to identify the high-yield complications. While these patients might just present with back pain initially, ankylosing spondylitis can lead to osteoporosis and vertebral fractures, aortic regurgitation in the heart, and even cauda equina syndrome. Having said that, you should also know that most patients actually do really well. There's usually no functional or employment disability for the majority, and overall mortality and life expectancy generally stay completely normal. Entering the neurology unit, we're going to finish by challenging you on the pathogenesis of brain lesions. A patient comes in with a headache, maybe a fever, some focal neurologic deficits, and their MRI shows a ring-enhancing lesion. The primary question you need to ask yourself is, did this come from direct spread of an adjacent infection, or was it hematogenous spread from somewhere else in the body? Take a look at this MRI. Notice the classic ring-enhancing lesions with central necrosis. The rule of thumb here is absolutely crucial. A single abscess usually indicates direct spread from a nearby source. Multiple abscesses, on the other hand, strongly suggest hematogenous spread, maybe from something like endocarditis or osteomyelitis. See how this pathogenesis builds on itself? Predisposing problems map directly to specifically affected brain lobes. If the patient has otitis media or mastoiditis, the direct spread typically hits the temporal lobe or the cerebellum. If they have frontal sinusitis or a really bad dental infection, that direct spread is targeting the frontal lobe. Meanwhile, hematogenous spread tends to cause multiple abscesses right at the gray-white matter junction along the middle cerebral artery distribution. Now, this is your exact diagnostic differentiator between a brain abscess and TB meningitis. A brain abscess gives you that focal ring-enhancing lesion and focal neurologic deficits. Tuberculosis meningitis, which happens pretty often in HIV patients, presents with basilar meningeal enhancement and hydrocephalus on imaging. Plus, their CSF will show an extremely low glucose, elevated protein, and a lymphocytic pleocytosis. Let's walk through the next best steps for that brain abscess. You don't just guess the bug here. Tissue diagnosis via CT-guided aspiration or surgical biopsy is absolutely required to get a gram stain and culture. Only after you secure that tissue sample do you commit the patient to the necessary prolonged antibiotic therapy and potentially further surgical drainage. Okay, here is your rapid-fire summary of the most actionable diagnostic and management takeaways from today's rounds. For healthy outpatient CAP, think macrolide or doxycycline. For suspected endocarditis, pull 3 blood cultures before you even touch the antibiotics. A right-sided varicocele that persists when lying down? That demands an ultrasound to check for malignancy. And a brain abscess requires aspiration for tissue diagnosis. You've mastered the algorithms as they stand today, relying on specific antibiotic classes and clear anatomical pathways. But with shifting antibiotic resistance profiles across the globe, our trusted empiric next best steps are constantly at risk of becoming obsolete. You've got to keep studying and keep adopting. Catch you in the next explainer.